Good evening, ma'am.
Good evening, ma'am.
Good evening. Hi, am I audible?
Yes.
Yes, you are, ma'am.
Voice is clear, na? I'm not using any earphones or headphones. This is okay?
Yes, this
Yes,
is
ma'am.
perfect.
Perfect.
Okay. Should I check my PPT once?
Yes, ma'am. Please do that.
Okay, how do I do it?
Ma'am, are you getting an option of sharing your screen?
I'm trying to do that.
Hi,
Okay.
Surabhi.
Hello, sir. Hello. How are you, sir? Is my
I'm fine. Anup joined.
Yes, Dr. Gaf.
I'm trying to share my screen. Is it okay?
Yes, ma'am. It's
Okay.
visible. Just please go through the presentation to see if anything is lagging or if that's all good.
Okay.
It looks perfect, ma'am.
Hi, KU, Jessica.
Good evening, sir.
Good
Good
evening.
evening, sir. How are you?
Rutvan, yes, I haven't met any one of you, I presume.
Good evening, sir.
Good evening. Good evening. Anup has joined in. Yeah.
Yes. We are already live on YouTube. So we're just waiting
I know
for
you.
the...
I know you all had discussions earlier. Sorry, I couldn't join any of those sessions. But you're
No
organizing
problem,
it.
sir.
You're very thorough and very systematic. I'll be following everything in the WhatsApp group. Wonderful job.
Thank you so much.
Thank you, sir.
Surabhi, how is it going? Ahmedabad.
Ahmedabad has already started becoming hot, sir.
As is in Chennai.
Yeah.
And KU, where are you studying?
I'm sorry.
KU. Rotary and KU Sapnis.
Yes, sir. Good evening,
Where are you
sir.
studying?
I'm from Rajiv Gandhi, sir. Rajiv Gandhi Medical College.
Okay. What do you do?
I am a medical student, sir. Third year.
Third year. Wonderful.
Yes, sir.
Wonderful. Dhruvan?
The same college, final year.
Okay. Jessica?
Sir, I'm in my internship currently.
Oh, which college?
Sir, Kashibai Navle, Pune.
All right. Okay. Wonderful.
You people are doing a great job. Must congratulate you all.
Yeah, the only way of, solving problems like AMR is youngsters should come forward. We are all old, we have done our work, at least, done part of our work.
Correct.
But youngsters can make a change. It's very difficult to change the attitude of old people like ours. But, when
So,
we,
but it's
when
actually,
we use, ideas or youngsters' brain, they will get it implemented. And at least the future generation will make a change. That's why we need your help. We can take it forward.
that's our hope, sir. We'll be working on the principles that you will be laying down. So I think your contribution is actually greater than ours. What we can do is just hope to open the eyes of the current generation, sir.
We all work collectively, we all collect, like individuals, organizations, everybody. If you all do that, or you bring forward all the medical students together, I'm sure in the country will make a big change. And you can do that because you youngsters, I've been closely following up what you do, as I mentioned. You're very systematic and you can do that. Anup, good afternoon.
Good afternoon. Good afternoon. I'm audible, right? Audible.
Yes, Anup. And the Wang is from your team, isn't it?
I think Mr.
Jessica,
Devang is an attendee.
All right.
Yeah. So, Mr. Devang, we'll be having another link for the attendees, which is going to be a YouTube live session. We have already sent the link for the same, so you can join through that. This is only for the faculty members.
Okay, now youngsters, I'll be speaking only for a minute maximum when you ask me to speak on the just introducing AMR Declaration Trust and our collaboration. Not more than a minute, maximum 2 minutes, not more than that. No?
No problem. So you can take as
You'll
much
be
time as you need.
controlling the meeting is, and you are the people controlling the meeting, controlling the flow, everything. By the way, I just got this, I ordered for this book called Candid. This is written by a journalist on Indian entrepreneurs in medical field and biotechnology. You people should read it. Maybe in future, what I'm working on apart from AMR, I'm trying to, introduce, at least inspire youngsters, young medics to be entrepreneurs. That's the only way our country's science can progress. We are all doctors doing wonderful job in treating patients, but we have got a bigger responsibility, like be entrepreneur, invent, discover as teams by collaborating with the biotechnologies, other fields. And maybe, we in future, we may have some collaboration on that as well to make that change. I'm talking to the people close to government to introduce that concept into medical curriculum and other areas, working with entrepreneurs as well. So we may have to work on that in future.
You really hope so, sir. We just wait for a few more minutes. Let more people join in. We already have 30 viewers. I think we'll wait till 5:30, which is our original time to begin, and then we'll start with our session, sir.
Yeah, I think 4 or 5 minutes. So just one thing, came to my mind suddenly. Sir, Gafur sir, I did my MBBS and MD from Surat, Government Medical College, Surat. And after that, I settled in Ahmedabad because my husband got a vacancy here in public health, PSM. And, because he got a vacancy here and he was posted in Ahmedabad, so I also settled in Ahmedabad. And then I started practicing as a physician, in a private practice. So I could manage diabetes well, hypertension well. But the moment any person used to come to me, with sore throat, cough and cold, I used to be so confused. What do I do? I used to write levofloxacin and I used to write, so that was, that moment was those few days when it was just few days I practiced as a physician. And that was the time I realized I don't know anything about infectious diseases. So the teaching of ID in MBBS and MD was so suboptimal. That time I realized that no, I have to do something. Otherwise I can't, I don't know even to manage common cold. And, that day I approached Dr. Atul Patel, who was practicing as ID consultant in Ahmedabad. Of course, he's practicing at present also. And he said, no, if you want to do ID properly, you go to Hinduja and do it under Dr. Soman. So that is how the ID thing, came into my life.
You're right, Surabhi. That's the situation. When I did my MD long way back, I read the Harrison 3 times, except the section on infectious diseases.
Yeah,
except.
I
thought,
agree.
what should we read? We see dengue, typhoid every day, and we know everything. Why should we read about antibiotics? We use it right and left, and we know everything about antibiotics.
Yeah.
Only later I realized when we properly received training on antibiotic, I did not know anything about infectious diseases, really. And especially I didn't know, even though, yes, experienced infectious disease after MD, but didn't know anything about antibiotics. The basic difference between amoxicillin and piperacillin tazobactam after my MD,
Yes.
I was not aware. Only I realized later. People, Indian doctors, we know that we believe we know, but we don't know. And it's difficult to change that attitude.
Yeah.
And that's what we need from medical students. It's not their fault. It's not the fault of doctors. It's a fault of the education system.
Absolutely, sir. So I think the medical students should not feel guilty at all that they don't know, because it is our failure as a medical system. So the fellows, all the fellows, when they join, afresh after passing their MD as in infectious diseases, it takes a lot of time for them to, undo whatever wrong they have learned. And it is very difficult for us to make them understand that we have learned nothing till MBB and MBBS and MD. I can't remember any prescription in my MD medicine days without ceftriaxone.
Right.
Whether it was dengue, whether it was neurology, whether it was rheumatology, ceftriaxone used to be there.
Yeah.
So even as right now, what we know from our, when we go for our postings, etc., if we ask a resident, and why is this antibiotic given? They'll either say that, our seniors told us for this disease, you just give these 3 antibiotics or something, or it's just, prophylactic cover. And that is, I think, a mindset that needs to change of not just our seniors said, so we were taught this way, but rather question that why are we actually giving it? That will help prevent a generalized resistance to almost every kind of antibiotic at this stage. Even in the ICU, we see like 5-6 antibiotics of the same class being given. And because we were in the second year that time, we knew our pharmacology very well. So I was once, as an oversmart kid, I went and asked one of the residents that, it's the same medicine, why are you giving it twice? They got kind of furious that, you shouldn't have questioned us. We were taught this way, this works, just go. And that's when I realized that it's not exactly their fault, because they're also overburdened to actually learn. But if it's something that's ingrained into us, which hopefully it will be soon, that the same thing shouldn't be given twice in a higher dose just to hope for a change. That's something that will hopefully go a long way in preventing an AMR pandemic someday.
Right. Yeah, 5:30. Yeah.
It's 5:30. I think we can begin. We have
Yes.
80 participants at the moment. I'm sure they'll all join in sooner or later.
All right, I think we can start. Aishwarya, all set on YouTube, right?
Yeah, the live is going on smoothly.
All right, perfect. Just put it up on Instagram as well.
Okay.
All right. So good evening, everyone. I, Rotaractor Dr. Jessica Gupte, welcome you all to today's session on Prescriber Today, Steward Tomorrow, Addressing AMR with the Right Prescriptions, which is organized by the Rotaract Club of Medicrew in collaboration with the AMR Declaration Trust. A very warm welcome to our esteemed members of the AMR Declaration Trust, our speakers for the day, our panelists, and to all our attendees. Before we move ahead, I'd like to give you all a short introduction about what Rotaract Club of Medicrew is. So Rotaract Club of Medicrew is a non-profit organization under Rotary International, which is formed by the medical students and for the medical students. We consist of medical students and professionals from faculties such as MBBS, BDS, BPT, Ayurveda, BHMS, with the common aim of providing healthcare in every part of the country, spreading awareness on important topics in the community, and working for the service to the society. Our club motto is leading with healthcare through adversity to the stars. With numerous health camps, blood donation drives, awareness sessions, we help our members to become skilled medical professionals and leaders of the community. So to know more information about our organization, you can visit our website, or you can also visit our Instagram page, the details of which will be uploaded in our group description. So before we move ahead, just a few things to remember. Firstly, we want this session to be interactive. So we are going to be having a Q&A session at the end. So if you guys have any doubts at any point of time, you can just put it up in the comment section of the YouTube live, and it will be addressed by our speakers at the end. There is also going to be a post-event form which is going to be shared at the end of the session, which needs to be fulfilled in order to receive your certificates. Without any further ado, I'd like to invite Dr. Abdul Ghafoor sir, the Managing Trustee of AMR Declaration Trust, to take the session forward.
Thank you, Jessica. Good afternoon, the young doctors of our country. AMR is a socio-economic problem, and that cannot be tackled by medical students or medical community alone. It's a socio-economic crisis. And AMR Declaration Trust is a public charitable trust founded on the principles of Chennai Declaration. And Chennai Declaration is one of the leading initiatives in India and abroad on tackling antimicrobial resistance from the perspective of India and other developing countries. The Chennai Declaration initiative made a significant contribution on how our country look at the antimicrobial resistance problem with a very positive perspective. We contributed significantly towards multiple policy changes from Indian government in the area of AMR. We made humble contribution in increasing the awareness of the problem among medical community, policymakers, media, and public. After long work, after years of work organizations, countries, what we realize is difficult to make change because we, the so-called seniors, have fixed ideas. We have got so many issues at hand. It's very difficult to make change among the grown-ups. But that's not how students are. Students have got pliable mind, ideas. If you introduce a seed, implant a seed into the young generation's minds, it will grow like trees and it will bear fruits. What we need is from the youngsters, medical students, is to work in the area of AMR and to make that change that we could not do. We have initiated a change. You need to take it forward and make that change really happen on the ground in our country. Thank you.
Thank you so much, sir. I'm sure that's going to inspire every single medical student that is watching, and it's inspired us definitely. I already feel the spark in my eyes. I'd like to now call upon Dr. Anup to continue with the theme of the session today and to enlighten us all on a little bit of how the theme is going to go. Thank you.
So, good evening, all. So, as Dr. Ghafoor was mentioning, antimicrobial resistance remains a very complex problem. And what we have noted is that when we have these sessions, meetings, programs on AMR, usually each one of us ends up pointing fingers at the others, saying that you reduce in veterinary services first, you reduce in an antibiotic use in agriculture first, and then come and talk to us. There is a lot of over-the-counter prescriptions which the patients directly take. So why don't you give advice to the patients first, etc., etc. But in midst of all this, and while we realize that starting from the policymakers to a lot of, like Dr. Ghafoor is passionate about entrepreneurs on the ground who would like to make changes, end of the day, there is something which each one of us can do on our own without help from anybody, okay, which each one of us can do our own, and it is completely in our hands to do. That is, give the appropriate prescription for the right patient. Okay. So this is not rocket science. This is just good clinical medicine. This is just a byproduct of decent training and mentorship. And that is in our hands. You need not depend on policy changes or depend upon reducing antibiotic use in agriculture, etc., to ensure that you do the right thing. You can give the right prescription and you can do your bit to reduce or to contribute towards AMR problem. So the theme for today was this, the antimicrobial stewardship aspect, which is addressing how you can rationalize your prescription and how you can do the right prescription, and instead of either underuse or overuse of antibiotics, keeping the patient as the center. So even though on the background, we talk this as an initiative for AMR, as I mentioned earlier, this is a pure clinical medicine where we are keeping patient as the center of it and ensuring that the patient receives the antibiotic which he has to in the right dose, right duration, etc., etc., but also ensuring that he does not receive what he does not need in terms of adverse events, cost, and the impact on the ecology. So that is the whole focus of the theme for today. And I will start by inviting Dr. Surabhi, who's an ID physician based in Ahmedabad, who through a series of case discussion will try to illustrate what each one of us in our day-to-day practice for common clinical scenarios which we see, how can we rationalize our prescription in such a way that all of us contribute to control of AMR. I'll hand it over to Surabhi. Thank you.
A very good evening to everyone, and thank you all of you who have decided to, take forward this topic and learn through in the clinical cases based discussion, which is very, very important. So I'm trying to share my screen now. Is it visible?
Yes, ma'am.
Yes, ma'am.
Okay. So I have given the topic to my presentation today, when not to use antibiotics, because that is where antimicrobial stewardship, begins. It is a major part of AMS. So we all know that antimicrobial stewardship is a systematic measurement and coordinated interventions designed to promote the optimal use of antimicrobial agents, including their choice, dosing, route, and duration of administration. And that is mainly to optimize the clinical outcomes while minimizing the unintended consequences of the antimicrobial usage, including toxicity, selection of organisms like Clostridioides difficile, and emergence of resistant bugs. And we know that this is a major problem now, and it is acknowledged all across the world. And, this is one of the projections in 2050. This figure is very scary. These many people are going to die per year all across the world because of antimicrobial resistant bugs. So yeah, we have to learn now. It's late, but yeah, we can learn through discussions and through presentations like this, which we have been doing for a long time now. The major problem is that, as Dr. Anup was mentioning, there are various challenging towards practicing AMS, especially, India is a special scenario because we have over-the-counter medicine, self-medication is a routine practice, and numerous unapproved combinations without proper PK/PD match are available. And again, infection control practices are grossly inadequate. Also, this is another very, very, potential area and major challenge, because the antibiotic pipeline is, so antibiotics are one area where we do not see more and more molecules coming up very easily and fastly. And there are a lot of reasons. I won't go into the details. So there are market challenges and financial aspects and research aspects. So it is difficult to develop new antibiotics. And then once they are in the market, their usage has to be controlled. So all these issues are also associated with this. So with the dearth of the new antibiotics in the offering, what we are left with is only one solution: to preserve what we are left with and to rationalize its use. And that is what we call as antimicrobial stewardship. So what I will try to do today is, with the help of some myths which are associated with the antibiotic usage and with the help of some clinical cases, I'll try to illustrate. So the first myth is, all illnesses with similar symptoms require antibiotics. Now, a 45 years old female patient who is a known case of diabetes uncontrolled diabetes. She presents to us with fever, myalgia, sore throat, dry cough for 2 days. So what do we think is the appropriate treatment to treat this patient at this point of time? Azithromycin, levofloxacin, amoxicillin, cefixime, or none of the above? So we have already discussed this shortly, and we know that this patient is most likely suffering from a viral URI. Still, we know that upper respiratory infections in the outpatient department, that is the most common reason for antibiotic prescriptions which are not actually needed. It is all across the world. It doesn't apply only to us. And, if we talk about the organisms which cause upper respiratory infections, especially acute pharyngitis in adults, it is mainly the viral infections. Very rarely we have group B streptococcus, that is Streptococcus pyogenes, which also can cause this kind of presentation. But then, with the help of just the color of the sputum or the cough, the duration, the pattern of the cough, it is not always possible to differentiate between the two. So what I usually do in my clinical practice is, for initial 3 to 5 days, I strictly avoid any antibiotic. And if there are any warning signs, like patient is having high-grade fevers with leukocytosis, or there are other signs which are suggestive of bacterial infection, any significant lymphadenopathy, then only we start thinking of prescribing antibiotics in such patients. So the common clinical situations for which antibiotics are misused in the community are, acute bronchitis, common cold, other non-specific upper respiratory infections, viral pharyngitis. Then there are conditions for which antibiotics might be indicated, but then they are overdiagnosed. For example, we know that streptococcal pharyngitis mandates starting antibiotics, but then we overdiagnose and therefore overtreat it with antibiotics. Again, then there are some conditions for which antibiotics are needed, but then we use the wrong antimicrobial class, agent, dose, duration, and that is because our knowledge is not optimal about the usage of the antibiotics. Because, before we write even a simple amoxicillin, we have to know what are the organisms which we are suspecting when we write amoxicillin, and what are we trying to cover with that antibiotic. So that is the knowledge which is lacking a lot of, in most of the, at least, the MBBS students and MDs, they are lacking in this knowledge, and this is where we need to, do better. So there are conditions for which watchful waiting or delayed prescribing is appropriate, but then that practice is also underused. For example, we know that in patients with sinusitis and otitis media, these are the potential conditions where we may use antibiotics if needed, but then they don't have to be started on day 1. So coming back to this patient started levofloxacin on her own, and later on day 4, she consulted a doctor who advised her to stop antibiotics, as he was sure that this infection was viral. Now, this patient is very much worried about stopping the antibiotic course in the midway. So that again brings us to this question. This is a very age-old saying that once you start an antibiotic, you should complete it. So that applies only to those conditions where we have started the antibiotic optimally. So this patient, once we are sure that it is a viral infection, we should stop the antibiotic straight away. Now let's discuss another case. This is a 32-year-old female patient admitted with confirmed dengue fever with kidney injury and low platelet count. Which of the following do you think is correct? Treatment with antibiotics is must as the infection is complicated. There is no need of treatment with antibiotics as dengue fever is a viral illness. Decision about antibiotics should be taken based on the WBC count, and antibiotics should be started if we have a low WBC. And antibiotics help in the recovery of dengue and may be considered for initial 2 to 3 days. Now, these 4 options I have put here because, people are, when I ask them not to start antibiotics in dengue, they give me these justifications. And I think all of us have these, doubts in our mind that, In dengue, there is a chance of secondary bacterial infection. If there is leukopenia, then the patient may have a secondary bacterial. Then people are worried about, complicated dengue, that here we should use antibiotics. So the answer to to this question is that there is no need of treatment with antibiotics in a viral infection like dengue, as it is a viral illness. And the leukopenia and all the cytopenias, they are very fastly recovering in dengue, and there is no study or no guideline which says that to prevent infections in such patients we should start antibiotics unless there is an established secondary bacterial infection. The second myth is prescribing antibiotics prevents infections. I think this is one of the major reasons why antibiotics are used by our surgeons and our intensivists for critical patients who have a lot of devices and who have undergone surgeries. So let's see this case. This is a 65 years old male patient who has undergone CABG, and in hospital he has received surgical site prophylaxis, cefazolin and teicoplanin. And then this patient was discharged on moxifloxacin and cefuroxime for 7 days. 1 week later, this patient is admitted with surgical site infection due to an organism called nocardia. And this is the picture of his surgical site and the CT, which is already showing an infection established there. Similarly, this is a case of 55 years old female patient who has undergone total knee replacement, and antibiotics were given by the orthopedician throughout the indoor stay. And then this patient was discharged on linezolid and ciprofloxacin for 7 days. And 1 month later, she presented with prosthetic joint infection due to an organism called Klebsiella pneumoniae. And as you can see here, it is resistant to VLBLI combinations and a lot of other groups of antibiotics. So the reason of presenting these 2 cases was just to give you an idea that continuation of antibiotics for long duration after any surgery never helps to prevent infections. Preoperative or perioperative antibiotics should be strictly given as per the recommendations, as per the national and international guidelines. And these antibiotics, at least in clean surgeries, they are basically recommended to cover the resident flora, not the transient flora. So what do we mean by these 2 terminologies? So whenever a patient is taken for any surgery, the local antisepsis takes care of the transient flora which is present superficially on the skin, which may consist of gram-positives and gram-negatives organism. However, there is another flora which is deep down in the skin that we call as resident flora, and which comprises of Staphylococcus aureus and coagulase negative staphylococci. So in these surgeries, apart from those antibiotics which cover these 2 organisms, there is no role of using any other antibiotic. And again, there is a recommended period where the antibiotic when it should be administered, because the risk of infection related to any surgery is maximum when the wound is open, so before the closure of the wound. So therefore, the duration of the timing of antibiotic that has been prescribed as 30 to 45 minutes prior to the incision. And again, there is no role of prophylactic antibiotics for any invasive device like, central venous catheters and urinary catheters or endotracheal tubes when the patients are there in the ICUs. Another very important point is, all the guidelines, they have suggested that the duration of antibiotic administration should not be more than 48 hours in surgeries like CABG, and all other clean surgeries. You have to just give 1 dose or maximum 2 doses of, when the patient is operated. After that, there is no role of giving prolonged duration. And this is a very common practice, not only in private setups, but we know that in government setups also, patients receive prolonged duration of antibiotics after surgery. Another myth which is commonly floating is that all positive cultures should be treated with antibiotics. So this is again one area where antibiotics are significantly overused. So let's see this patient. This is a 34 years old female patient who is a known case of diabetes. She's totally asymptomatic and she goes to a physician for her routine tests. Now the physician finds some pus cells in the urine routine and therefore he orders a urine culture. And he finds that there is E. coli in the urine culture with a significant colony count. So what do you think the physician should do here? Should he start cefoperazone sulbactam, piperacillin tazobactam, cotrimoxazole, or none of the above? So this is a very sensitive bug and all these groups of antibiotics are sensitive. So this brings us to discussion of asymptomatic bacteriuria. So this is a patient with bacteriuria but no symptoms present. She doesn't have any urinary symptoms, any constitutional symptoms, and she has gone to the physician for her regular diabetic follow-up. So asymptomatic bacteriuria, which is defined as presence of bacteria in the urine with a significant colony count, or colony count may not actually matter, but the patient being totally asymptomatic. So it should not be treated except in patients who are pregnant and patients who are going to undergo any urological intervention. There are some centers who and some guidelines who advise checking for bacteriuria in patients post-kidney transplant also. And similarly, asymptomatic candiduria, which is again a very, very common entity in diabetic patients, in elderly females. It should not be treated again except in patients who are significantly immunocompromised, like neutropenic patients, again, patients who are going to undergo urological interventions, and in neonates. And if you have a patient in your ICU who is, or in the hospital who is catheterized, and you find that there is candida isolated in the urine, so it is just the elimination of the predisposing factor, which results in the resolution of candiduria. So you just remove the catheter, and that is sufficient for that kind of situation. Now let's see this thing. Which of the following is an indication to prescribe antibiotics or antifungals? Klebsiella pneumoniae in urine culture of a patient who has dysuria with a significant colony count. Candida from bile culture in a patient on mechanical ventilator, and E. coli in stool culture. So we have discussed this, that this is a patient who has symptoms and has got bacteriuria with a significant colony count. So this is the patient A is suffering from UTI and we have to treat it. On the other hand, E. coli, which is a normal flora from the stool, does not need treatment unless we are dealing with, very special scenarios where the patient is having, very bad dysentery, or patient is very toxic in sepsis. Similarly, if we have candida isolated from any respiratory specimen, whether it is sputum or whether it is endotracheal tube or tracheostomy culture or bile, in patients especially who are on mechanical ventilator, that just reflects colonization of the bronchial tree, which is very common in critically ill patients, especially who receive mechanical ventilation. Candida pneumonia and lung abscesses are extremely uncommon phenomenon, and it is basically a histopathologically diagnosed, pathology. So using fluconazole just for candida, which is isolated from the respiratory cultures, is absolutely not advisable. Now let's see this case. This is a 57 years old male who has who is suffering from diabetic foot, and he has undergone below knee amputation. Unfortunately, this the stump got infected, and the wound swab, when the patient was suffering from infection with all the clinical signs, grew a carbapenem-resistant Acinetobacter species, which was sensitive only to colistin. So this patient was treated with colistin for 19 days by the surgical team. And now the surgical team is planning to close the wound. But they send a wound swab again, and it grows the same bug. So what do you think is the most appropriate management at this point? This is how the wound looks after the treatment with colistin. Should we still continue treatment with colistin as the swab is still positive for Acinetobacter? Should we treat the patient with colistin and carbapenem combination right now because, this Acinetobacter is not going? Should we go ahead with wound closure followed by antibiotics or none of the above? So whenever we send wound swabs, we are always confused. So first thing, what we have to look for is, we have to always correlate our cultures with the clinical syndrome and clinical condition of the patient. Now, if we look at this patient is absolutely fine, no signs of sepsis or any infection. And if we look at the wound also, it is a very healthy granulation tissue. There is no pus at all. So this patient basically has been treated, and now the swab which is showing Acinetobacter may not have any relevance, because we know that the wound swabs are never good specimens, and all these open wounds, they are colonized with multiple organisms, and just growing one or the other bug in the culture may not mean anything, and therefore we should not jump on starting the antibiotics just treating these organisms which have grown from the wound swabs. Now, this is a 60 years old female patient who has presented elsewhere with fever, weight loss, loss of appetite, abdominal pain with vomiting for 2 months. CT abdomen was suggestive of abdominal TB. So she had lymphadenopathy and she had, intestinal involvement, which was suggestive of COX. Lymph node biopsy was done and she was started empirically on AKT. Now, the primary stain, the ZN stain, also showed acid-fast bacilli. Patient showed marked improvement on AKT. 15 days later, she visited the primary consultant with the report of TB culture, which was positive for non-tuberculous mycobacteria, which had actually grown within 7 days in the lab. And therefore, the consultant asked the patient to stop AKT and start the treatment for non-tuberculous mycobacteria. However, the patient at this point was confused and wanted to take a second opinion, and she came to us. So when we reviewed the history was very perfectly fitting into TB, and patient had actually showed signs of improvement on AKT. So we just asked her a simple question: how was the lymph node biopsy taken? So it was an EUS guided biopsy. It is an endoscopic ultrasound guided biopsy. So yes, a scope has been used here. So non-tuberculous mycobacteria were most probably contaminants from the endoscope, which had actually grown in the lab. We advised her to continue the same AKT, and 3 weeks later, the AFB cultures did grow Mycobacterium tuberculosis, and the patient did well on AKT. So the learning point from this case is, just knowing the organisms is not important. We have to know what is the organism fitting into the clinical syndrome. Is there any risk of contamination or contaminant or colonizer which has grown in the culture? So all these things are very, very important. And we know that non-tuberculous mycobacteria are the organisms which are present in our environment. They are present in water, they are present in soil. So whenever these endoscopes, which are used for different procedures and mainly the diagnostic procedures, or even surgical procedures, the laparoscopic surgeries, if these scopes are not properly disinfected, there is always a risk of these organisms growing or even causing secondary, hospital-acquired infections, which is because of these disinfected scopes. Another myth is, many people, they still think that all these diagnostics, the cultures, especially the blood cultures, the other cultures, they are unnecessary and they are costly, and we can always treat the patients empirically. So let's see this case. This is a 21 years old male patient who presented to us in December with high-grade fever and chills, vomiting, loss of appetite, significant weight loss going on for last 5 months. So he had taken multiple treatments and antibiotics from various doctors in these past few months. And in October, he was admitted in a hospital elsewhere in Ahmedabad, in my city, where they found that he had a rheumatic MR with mitral valve prolapse with a vegetation on the posterior leaflet of mitral valve. So he was perfectly started with crystalline penicillin and gentamicin for for, the most common community-acquired organisms which cause this kind of endocarditis, that is the viridans group of streptococci, and these are I think they have tried to target those bugs. Now, patient initially showed some improvement, but then he was not doing good, and then he presented to us after almost a month of this injectable antibiotic treatment. So what we found in echo was that there was a vegetation still present, and that looked like a semi-healed sort of on the posterior leaflet of mitral valve with significant MR. But the patient was still losing weight, he was still throwing fever spikes and not doing good. So what we decided to withhold all the antibiotics for 7 to 10 days as he was hemodynamically stable, and asked to do blood cultures thereafter. And his blood cultures grew Enterococcus fecalis. Now, Enterococcus fecalis, CP, crystalline penicillin, Genta, they are good antibiotics. But unfortunately, as you can see in this culture report, when penicillin, ampicillin, as well as the high-level gentamicin has been found to be resistant. So this was a resistant bug, and therefore this patient was not responding to this treatment. So the learning point is that in all these kind of patients, especially when we are dealing with or suspecting infections which are not the usual very simple community-acquired respiratory infections or community-acquired cystitis, try to send blood cultures or other appropriate cultures in all the patients who present to you with these kind of symptoms where you have fever, suspecting bacterial infections. That is always cost-effective, and it is associated with better outcomes, reduced mortalities, reduced morbidities, which has been proven again and again. And this is, I think, the most common reason why doctors are not afraid of starting antibiotics. So one thing which they are afraid of, that what if my patient does not get well if I don't give any antibiotic? And of course, what is the harm in starting antibiotics? Let me start it. So we now know that there are harms associated. Of course, we are discussing about antimicrobial resistance at present. But if we talk about the harm at personal level, so this case will show us, this is an 11 years old female patient who, had acute onset high-grade fever with cough, 3 to 4 spikes of 102 to 103 on 26th of November. So the parents were very much panicked because this patient has got history of febrile seizures in the childhood. And, they did the blood investigations on day 1. The WBC counts were normal. However, the pediatrician, he started the patient on tablet cefixime, 200 milligrams PD. A day later, this patient developed a rash. So this rash started from the trunk, and then it spread to the upper limbs, the lower limbs, back, including the face, very fast, within 24 to 48 hours. Also, there was involvement of the lips. There were ulcers in the oral cavity and redness of the eyes in the next 2 to 3 days. And actually, the fever increased in intensity. So I'll show you the rash. So this is her trunk and chest, and you can see her lips. I don't have the picture of the eyes, but there was conjunctivitis present. So the antibiotics were changed by the pediatrician at this point to piperacillin tazobactam. Now, at this point of time, the patient, because she was getting sicker and sicker, she was admitted to us. So there was a generalized baculopapular rash with involvement of the oral cavity, conjunctiva, and even genital mucosa. So now by this time, we knew that this is a drug reaction, and most likely this was beta-lactam antibiotics associated Stevens-Johnson syndrome. So this patient, she spent a lot of time in our ICU followed by ward, and her total bill was around 96,000 rupees. So the learning point from this case was that we know by now that, she did not need any antibiotics to begin with. And once we have started antibiotics, then we have to review our prescriptions. We have to review why she has developed all these funny symptoms even after starting antibiotics before jumping to, another group and another antibiotic of the higher antibiotic of the same group. So AMR, as we know, is a financial burden. There are patients who are admitted in the wards and ICUs because of antibiotic-associated issues. In fact, today only I discharged one of my patients who had Clostridium C. difficile, Clostridium difficile pseudomembranous colitis after she was given 3 days of cephalosporins after an LSCS. So again, an area where antibiotics were not needed, and she was admitted for almost a week in a bad shape with AKI and hypotension just after she has delivered. So it's a sad state of affairs. So what are the different adverse drug events which can be related to antibiotics? We see a lot of allergic reactions, pseudomembranous colitis. Of course, there are drug interactions which have to be kept in mind when we give antibiotics when the patients are on multiple drugs. And then there are specific antibiotics, specific side effects, So we have to handle the antimicrobials with care. We have learned from these cases that when we try to use antibiotics, we should know why we are writing that antibiotic. Even if you are writing a simple moxicillin or augmentin or, a very basic antibiotic, please know what are the organisms you are trying to cover with that antibiotic, what should be the ideal dose and what should be the duration. All this knowledge is extremely important if you want to treat your patients properly. And as Dr. Gafoor already mentioned, antimicrobial stewardship is not the business of a single person or only doctors. It is a teamwork which is important when we are dealing with this big challenging issue today. Thank you so much. I would like to invite if there are any questions. Thank you.
Thank you so much, Dr. Sirbhi ma'am. We'll be taking the questions at the end of the second session as well to help. We've already gotten a lot of questions on our YouTube live. So I think we'll wait till the end of the session so that we can have all the questions together. Viewers, I'm sure this was an extremely enlightening session. It was for me, definitely. I got a lot of a clinical edge in what to do and what not to do. And as ma'am said, when not to prescribe an antibiotic. Being medical students, I think it's important that we also know how the current MBBS curriculum is pairing in preparing us to be stewards in the future and not just prescribers. I'd like to now call upon Rotaractor Keyur Subnis, a medical student from Mumbai, to give his thoughts on how the MBBS education and the MBBS curriculum is playing a vital role and what the challenges are in the same. Take it away, Keyur.
Am I audible?
Yes, you are, Keyur.
Okay. A very good evening to all my esteemed colleagues and distinguished guests. I am Rotaractor Keyur Subnis, and I'm a director and a unit member in the Rotaract Club of Medical. As we gather under the banner of medical progress, let us heed the words of Alexander Fleming, whose accidental discovery paved the way for the antibiotic era. Penicillin cures, but wine makes people happy. With reverence for his wisdom, we embark on a journey to scrutinize the present landscape of MBBS education in India, where the seeds of antibiotic stewardship are sown. Sir Alexander Fleming, while accepting his Nobel Prize, he issued a straightforward warning to us. The thoughtless person playing with penicillin treatment is morally responsible for the death of many who succumbs to the infection with penicillin-resistant organisms. For all those who aren't aware about this, recently at the National Institute of Health in Britain, one of the most dreaded infections was reported. It was KPC. KPC is Klebsiella pneumoniae carbapenem resistant. No one knew what to do. No one knew where it came from. We have already stepped foot into this pre-antibiotic era, where everything that we have will work no more. But it's yet not too late. There's time for action. So AMR in today's MBBS education Is it even relevant? Is it even a part of it? Is it even taught? Let's find out. The current education system has made efforts in implanting antimicrobial resistance or AMR to shape the nation's young minds at the very molding stage of their life. They've successfully, just a minute. Yes. So they've successfully inculcated it into our curriculum. In addition, the system of clinics in the second year of the course encourages towards research and establishing a collaborative approach has been a breakthrough. AMR acts like the main drink for a few MBBS subjects like microbiology and pharmacology, and a mixer in case of clinical subjects like medicine, pediatrics, surgery, obs and gynae. Talking about microbiology, it's not just all about what occurs below the lens. In fact, they're the biggest combatants against AMR in this war. Antibiotic resistance in our syllabus is like that 16 megapixel lens of an Apple iPhone. It's been there right from the first device. But the addition of what is stewardship? Why is it needed? What role does it play? How does all of this contribute in curbing AMR? It can be counted as the best contribution to our system because now it's part of the curriculum, has to be studied for every internal and final examination. Okay. Now, talking about pharmacology, as we know, the idea of resistance and stewardship, how prudent use of antibiotics is, in which situations can we actually use prophylactic antibiotics? I would really like the audience to add into the comment section which antibiotics and in which situations do we actually give prophylactic drugs as a treatment. Not only this, but our practical syllabus includes a huge question, which is actually which has a large chunk of marks for correct prescription writing. Now, when it comes to clinics, it's never enough to talk about. As we all know, during the regular clinical posting rounds, we learn to apply our knowledge, especially what medicine is to be given to a particular patient. And it's this time that we learn to be more prudent. We grasp the ideology of rational use and overpower the misuse and overuse concept with all that we have learned. To add on, routine clinical practice of hand hygiene, donning and doffing of personal protection equipment, precautionary measures that are taken during our clinical postings, it just makes it a reflex action by the time we practice as doctors. In our educational system, fostering a culture of research within MBBS programs a pivotal role in enhancing student comprehension of antibiotic resistance and stewardship. By incorporating research opportunities into the curriculum, we provide students with a platform to engage critically with the evolving challenges of AMR and the imperative of stewardship. Now, our education system, just like it includes early clinical exposure, it also encourages the exposure of budding doctors to microbiologists, to pharmacologists who are actually infectious disease control specialists, and they're from different hospitals. This is going to promote cultivation of different ideologies in curbing AMR and how to prevent it in these young doctors. As we all know, with the addition of next examination, NEXT, everything has now taken that scenario aspect. All questions are coming in as scenario-based, case-based questions. This system is encouraging students to apply their theoretical knowledge right in the first year of their MBBS. This obviously fosters us to develop critical thinking about everything in addition to making decisions, the decision-making skill that is required. Do we have any challenges? With so many opportunities, obviously come certain challenges. The teaching material isn't very up to date with the current guidelines. Not very adequate clinical exposure is given. Not very sufficient faculties are actually present. All of this hinders into the effective education delivery. MBBS in itself is so vast that covering its own topics becomes difficult. Adding another new concept of stewardship into the syllabus and discussing about AMR, it's going to be a difficult task. Like a tradition, we can all agree here that there has always been an emphasis on rote learning. There is much more emphasis on passing examinations instead of encouraging critical thinking. It is unfortunate that some students are exposed to inappropriate prescribing practices as well by the teaching faculties, imbibing the incorrect practices and executing them in future. Now let's come to this case that we have come up with. I would like to add that this case is of a very close friend of mine from my institution. A 20-year-old girl experiences cough, sore throat, and stuffy nose. She suffered from similar symptoms 4 months ago. Instead of going to her family physician, she buys the antibiotic which has been given to her 4 months ago directly from the pharmacy. After taking 2 doses, she feels better and stops taking the tablets. After a few days, she starts feeling the same symptoms. However, now they're going to be more intense. So my first question would be, what could be the reason for the symptoms to become heightened? Secondly, is it appropriate to get antibiotics straight from the pharmacy? And third, what measures can we undertake to reduce such preference to pharmacies? Other than awareness, what can we do to curb this problem? Moving ahead, we got a lot of questions about what is an antibiogram. Antibiogram is an aggregate summary of susceptibility data of an institution. So it's an institution-based data. It's not common for a particular city. It's always based on the institution. But what I want to convey today is that there are 4 major facts that we all should know about an antibiogram. First, empiric treatment. Please get this word in your mind. It's about empiric treatment only. Antibiogram should only be used for empirical treatment. Second, consider the patient. Although antibiogram provides a very useful information, but you must consider other factors related to the patient and about the antibiotic that you have chosen. Is it a good choice for the infection suspected? Are there any other factors that could make any other antibiotic more effective than this one? Reevaluate. When the culture susceptibility testing report is available, reevaluate your antibiotic regimen. And lastly, know when to say no. Use established criteria to determine the presence of infection and causative pathogens. There's a possibility that the pathogen that you are treating is a virus, and in that situation, antibiotics are not a way to go. Coming to something that I would like to add on today, I'm sure all the doctors in the audience have ordered a bacterial culture at least once in their lifetime. Especially the medical students are learning about bacterial cultures in their second year. But at the microbiological level, there's something else that is more interesting that we should know, is to how to choose which antibiotics we should put into the panel of susceptibility testing. Obviously, there's no point in wasting these resources that you have antibiotic discs, so we are giving it for all antibiotics. No, you have to choose the right antibiotic for the particular panel. First, include only those antibiotics which are clinically indicated for the particular disease, either first-line agent or an alternative treatment for the suspected disease on an organism. Second, as per the hospital antibiogram, do not add those antibiotics which are actually seen to be falling under the organism's local resistance pattern. If my institution's antibiogram says that E. coli is resistant to amoxicillin ampicillin, do not add that into your antibiogram. Use a better antibiotic or an alternative. Do not add antibiotics to which the particular bacteria is intrinsically resistant. Fourth point would be, always include both oral and parenteral antibiotics wherever possible. Another thing that we should know is the antibiotics you consider should be locally available at your health setup. Decide on the site of infection. This is one of the most crucial points in this particular selection. If an organism is being isolated from the CSF, there is no point in giving the first, second generation cephalosporins. There's no point in giving oral antibiotics in this case. Similarly, if you're having a respiratory infection, there's no point in giving daptomycin. And the last but not the least being prediction of the susceptibility. If cefotaxime is seen to be resistant to the Enterobacteriaceae that you have suspected, ceftriaxone resistance can be predicted and can be avoided to be put into the panel. You'll be saving resources and time here. Now, I will be spilling some facts before I end my session today. Did you know that the terms have changed in the WHO's policy and even the CDC's? Current public information materials from the US CDC and public health care from England, they have replaced the term completion of the course with advocacy of taking antibiotics exactly as prescribed. So there's a difference between the two. WHO's One Health policy. Now, WHO is now promoting One Health policy. What is this? This is integration of human, animal, and environmental health sectors. Why so? Only stopping the resistance in the human health setup is not enough because antibiotics are given in veterinary settings as well. Cows, buffaloes, they're given antibiotics just as a prophylactic agent. Aquacultures are one of the biggest contributors towards antibiotic resistance. And at the same time, incorrect disposal of antibiotics into sewages or any other arenas is a very big problem. I'm not sure how many of you actually know about the NDM, that is the New Delhi metalloproteases resistant organisms, isolated from sewage from Delhi. So we are seeing that there is an association that is there between the veterinary setup, between the health setup of humans, and between the environment. Now, one thing I would like to comment here is that I'm not sure how many of you have realized, but this entire presentation was made blue in color. This was in association and accordance with the WHO's Go Blue theme against the antibiotic resistance. So before concluding my session today, I would just like to say that our ultimate goal here is to fight AMR as one family. That's it. Thank you.
Thank you so much, Dr. Keyur. You can stop sharing your screen. All right. Thank you so much, Dr. Surbi and Keyur, for this enthralling session. I'm sure all of us have learned a lot of things while going back. We have a few questions in a lot of questions actually. So I'll try to tackle as many of them as possible. If a few of them are left out, please do let us know in the WhatsApp group, or we can try and sort it out in an offline basis. All right. The first question is, how can antimicrobial stewardship programs help prevent the spread of antibiotic resistance? Dr. Surbi, would you like to answer this?
Very, the question which cannot be answered in 2 lines. So I would say that it is the antimicrobial stewardship only which can prevent antimicrobial resistance. So, see, AMR basically it's a terminology which has got so many aspects involved with it. So whenever the organisms are exposed to any antibiotic, they start developing some mechanisms which make them sturdy, which can help them resist those antibiotics. And that may happen even without the use of antibiotics by us. So if we talk about antimicrobial stewardship, that helping us in preventing AMR, so to a very big extent we can do that. And antimicrobial stewardship, we have already discussed, it includes the optimal usage of antibiotics. But yeah, resistance is, it's a very complex game. So these organisms, they are much, much smarter than us. So in the environment also, if they are exposed to any antibiotic, they would definitely develop some of the other resistant mechanisms. So as, Dr. Sabnis also presented, so it's One Health. We have to look into the environment as well as the other areas, not only the treatment in human beings. So yes, for us at present, it is mainly the AMS which can help us in preventing antimicrobial resistance. Yes.
Thank you so much, Dr. Surbi. The next question will be towards Dr. Keyur. How do we start antimicrobial stewardship in a medical college? Any practical advice for it?
Honestly speaking, if we actually want to establish stewardship, it's not a one-day thing to do. It's something that is going to take months and years to develop, but it always begins in the very small area, that is first forming an antimicrobial policy for the particular institution that you are in as to which antibiotics are supposed to be given for which infection. one thing that the WHO is encouraging is something called as the holiday policy of drugs. That is, after a period of time, you basically avoid using a particular antibiotic for, let's say, 6 months. Now, this is something that is under research still and is shown to be, having positive results towards reducing AMR. Ultimately, AMR is not inevitable until and unless we are still using antibiotics, but it can be prevented by doing these measures. Another thing would be setting up a stewardship policy, that is basically a committee which involves a microbiologist, a pharmacologist, all the clinicians who will come up together, and it's after all going to be a one thing, that is everyone has to act together, and keeping their own biases away, they can help in fighting AMR.
All right.
Sorry,
Thank
I
you
would
so much.
request, sorry to interrupt. I would request Dr. Anup Warrior to give his comments here, because he is very, very intensively involved in his institute, and he has, on his own setup. So many of us have done this, but I would like Dr. Anup Warrior to, say a few words here.
Thank you, Sudhir. So just reacting to that query on how to set up stewardship activities in medical college. So one of the core things is to build upon what Keyur also told about the committee, but instead of naming it just as a committee, I would like to use the term and a stewardship team which is empowered and supported by the ecosystem in the college, right? So end of the day, you need a team of people, and that team of people have to be empowered and supported by the organization, which is the medical college in this aspect, so that they will be able to carry out their activities. Now, that itself is a challenge in our setting, because the stewardship activities require two kinds of skill sets. It requires one, the core knowledge part, which obviously with our specialization and working in this field, which you can acquire, but it also requires a skill set of communication and how to implement things in a project mode. So you need a training of two sorts. You need this team to be trained both in the knowledge of antibiotic use and how to modulate antibiotic use, and also in the skill set of how to implement projects, what we call nowadays as implementation science or good communication skills, so that the change is possible in these settings.
Can I ask a doubt?
Yes, sir. Please, sir.
I do know that National Medical Council has issued a curriculum on antimicrobial stewardship to all the medical schools. What's the progress of the implementation of the curriculum? Do you have a separate specialty like antimicrobial stewardship, and who is teaching you on those modules?
Sir, actually, as much as I'm aware about this, in our colleges, we have antimicrobial resistance and stewardship is being taught under all the subjects after the second year, because first year we are not much aware about the concept of bacteria and antibiotics. In the second year, we have the subjects of microbiology and pharmac, which involves a lot in detail than what it was before, about what is stewardship, what is a stewardship committee, and forward strategies, backhand strategies, what is an antibiogram. All of this has been inculcated into our syllabus and curriculum, and it's been tested as well in our exams. So it makes us more no one can skip the chapters. Just that there's a lot to study, so we cannot skip the chapters as well. So it's been inculcated very well into our syllabus.
That's a very good. I know I've been talking to youngsters earlier. During my MD, I read the Harrison twice, but skipped all the chapters on infectious diseases. And there was no teaching on antimicrobial stewardship anywhere at that time. So it's very positive that the situation is changing. That's very encouraging news. Thanks, Keyur.
Thank you, sir. Thank you.
All right. The next question is for Dr. Survi. One of our viewers said that if you don't start doxycycline in a dengue case and in scrub typhus, you can be sued for negligence. Is there any case of that sort, or any proof in the pudding?
No, I'm not aware of why should be someone sued for negligence if you don't start doxycycline in scrub type. I mean, in dengue. Scrub typhus, I agree. Yeah, scrub typhus is an that's a totally different part of this. That's a bacterial infection, and doxycycline is the drug of choice. But when we talk of dengue, Yeah, there are a few studies and, which say that doxycycline may have some role in treatment of dengue, but it is not the established treatment. So there is no point of getting sued for not starting doxycycline in dengue. At least I have never started doxycycline till now in my patients with dengue. Sir, Dr. Gafur sir, would you like to comment here?
As Surabhi, as you rightly mentioned, there is limited evidence of doxycycline. Doxycycline has got antiviral activities. So many antibiotics have antiviral activities. Doxycycline, but there is very limited evidence for utility in the clinical practice against dengue. And we should not use doxycycline for dengue cases unless we have hardcore evidence. So nobody will sue you for not using doxycycline for dengue. But if you use a doxycycline and develop for some side effects, you may be sued.
Totally agree, sir. All right. Our next question is for Dr. Keyur. The question states that what is your opinion on regarding the use of combination of antibiotics? Can it also contribute towards resistance, or is that a hidden boon that reduces the dosage being provided?
As much as I'm aware, it's about like when you combine two antibiotics together, it's more about reducing the resistance. Because when you give a single drug, that there's a possibility that, let's say there are 10 bacteria, you give one particular drug, 9 of them die, but one of them keeps surviving every time. But when you give a combination of drugs, like usually what we give in tuberculosis, the tuberculosis regimen. So when you give 4 different drugs together, it's like not even one bacteria holds chance there. So it's like more to reduce the resistance than to actually increase the resistance in a person. So that is why it's been given for multiple diseases. We give the multiple drug regimens. That's
right. Thank you. Dr. Gafur, do you have anything to add to this, to what Keyur just said?
No, thank you.
Okay. Our next question is, what channels do we have to practically integrate the One Health verticals? I'll open this up to the panel. Anyone who would like to answer?
Anoop?
I think Dr. Gafur would be the ideal person in terms of the One Health and somebody who has interacted with all the stakeholders. So starting from be it governmental policymakers or veterinary or pharmaceuticals. So over to you, Dr. Gafur.
The mere concept of One Health approach. So we are all responsible for antimicrobial resistance. We doctors, the public, the veterinarians, the farmers. The reason is, if you look at the antimicrobial usage in the world, 70% of the antimicrobials are used, or antibiotics are used in animal farming as growth promoters to make the animals grow fat and fast. This is not to prevent infection in animals. This is not to treat infections in animals, to make them grow fat and fast. And 70% of the antibiotics manufactured by pharmaceutical industry used for this purpose. So unless we control that as well, if we just talk about antimicrobial stewardship in the hospitals by doctors, it will make limited impact unless we correct the irrational usage of antibiotics by farmers, by veterinarians, by agriculturists, by everybody. At the same time, we doctors are the one who face the patients dying due to antimicrobial resistance. The farmers don't face that. Veterinarians don't face that. We doctors treat the patients. We watch them die. So first, we need to correct our irrational antibiotic usage. We doctors should follow rational antibiotic usage. At the same time, make the policy makers and public understand that antimicrobial resistance is not because of the doctors. We are only a part. Our contribution to the whole AMR saga is only probably, I would say, 10 to 15% of the misuse of antibiotics in the world is by doctors. But we have the responsibility to correct ourselves. At the same time, raise the voice. We treat these patients. We have a moral responsibility to convince everybody all the components of antimicrobial resistance crisis. Thank you.
Extremely well said, sir. Resistance is actually a sum of all the parts, and we just form one of those components. I think it's important if we take the first step, then only the rest of the world is going to follow. Our next question states that how to restrict antibiotics in a hospital formulary Is there any strategy that must be followed? Dr. Sulbi, would you like to take this one?
Yeah, so see, basically it is the answer to that again is forming a program which should run in an institute, which starts from forming a stewardship team or a committee. And then you have regular meetings, infection control committee meetings. And when we talk about this committee, not only the ID doctor is one part. The infection control nurse, the management, the surgeons, everybody has to be a part of that committee. And then there are a lot of other things, like surveillance regarding the usage of antibiotics, the higher antibiotics, and then your infection control rates and your hand hygiene rates. So all these aspects are discussed, and so it's a broad thing which I cannot explain in 2 or 3 lines, but yeah. So it is a strategically formulated program which has to, which needs lot of inputs and lot of hard work and perseverance. That is what is most important.
Beautifully put, ma'am. Thank you so much. I think the next question is from Riddhi, who asks, how would you suggest the collaboration of microbiologists and doctors, and at which stage? At a clinical stage, academic stage, or both? Keir, would you like to answer that?
Yes. About a collaboration between the microbiologists. Now, first we need to understand how either of them function. Microbiologist's role doesn't only lie inside the laboratory, and the clinicians usually, I'm sorry to say, but sometimes there's this resistance inside them that, why should I listen to microbiologists? Because I am dealing on the ground level situation, and microbiologists are just doing the work in the lab. So I will give what I feel is right. So this is something that we need to, go past and join hands somewhere, because if the report is saying that something is resistant and you need to stop this drug, even if the patient is responding somewhere or the other, we should modify that particular regimen as the report says. So there's somewhere this collaboration is going to be very helpful, and this is actually something that is a stewardship. That is, you have a collaboration majorly between the lab workers and the ground workers. So this is something that is going to help in reducing AMR to a very significant level.
All right. Thank you so much, Keir. Our next question is one that has been tagged multiple times. It states that if we fail to give the correct or needed antibiotics on time, thinking it isn't the imperative, and a patient develops a severe infection or complication, will it count as medical negligence? Dr. Surbi?
Sorry, Drutvan, I lost you. I could hear the second sentence, but not the first.
I'll repeat myself, ma'am.
Yeah, sorry.
If we fail to give the correct antibiotic on time, thinking it isn't the imperative, and a patient develops a complication or a severe infection, would it count as medical negligence?
Of course, dear, it may be counted as a medical negligence, So, of course, choice of the proper antibiotic is one of the most important parts of the treatment of a patient which actually affects the outcomes. So yes, it can be counted as a medical negligence.
So keep in mind that appropriate means appropriate to the diagnosis. Okay, so this should not be construed as a way of using broad spectrum choices for all kind of fevers or infections, right? Thinking that let me cover everything possible under the sun because God knows what is appropriate, right? So the statement should not be construed in that fashion. The starting point is your clinical diagnosis, and the negligence part is what any reasonable peer of your training would do. Okay, it is not that we have to be magicians and pull out the diagnosis from thin air. So the idea of even with the negligence is that you should be able to practice medicine as any other reasonable person with your skill, education, and competence would do. So do a reasonable clinical diagnosis and choose a reasonable antibiotic as per the clinical diagnosis. Okay, not to be scared of negligence and use all sorts of things for all sorts of diagnosis.
Well said, doctor. Thank you so much. I think another question we've got, which has been asked multiple times, I think that's an impact of our session. people have asked us that how can one get professionally or like certifiedly trained in antimicrobial stewardship? Is there any course that they can do? I'll open this up one after the panel.
Yeah, so you have the WHO's massive online course, the WHO mock, which is one of the most what you call simplistic courses to take online, and that is one of those things. There are more advanced courses from British Society of Antimicrobial Chemotherapy and also the ID Pharmacist Society of the United States. So the WHO mock would be one of the starting points, I suppose.
All right. Thank you so much, sir. Okay, we have a viewer from Indonesia who's asking, what if the culture is still on progress in a critically ill patient? How to give antibiotics while waiting on the culture result? Kay, would you like to answer that one?
Could you repeat the second part, please?
If a culture is still, if you're waiting on a culture and the patient is critically ill, how will you give antibiotics to this critically ill patient?
As much as I am aware about this, there's a very short answer. Is usually we start with the empirical treatment. Let's say we know what kind, like we have some kind of a diagnosis in mind that this would be the cause of the infection. We start with a broad spectrum antibiotic, and usually it's like a combination of something that can act against gram positive and gram negative, or something that can act against aerobic and anaerobic. So it covers an entire area. Now, once we get the culture report, obviously the broad spectrum will work. But when we get the culture report, it's our duty as the physician clinician to change that antibiotic into what is more specific for that particular organism.
All right. Thank you so much.
No, and to add to that, so in all the infectious syndromes, you may not need a coverage broad enough to cover gram positive plus gram negative plus anaerobic. So it actually depends on the syndrome. What are the possible organisms which you want to cover, which are the possible, etiological organisms, and that is how you choose your empirical treatment. So sometimes you may have to choose gram positive with gram negative, but there are a few areas where you can just get away without choosing just gram positive cover empirically, and then you change the same gram positive cover after you get the culture report. So basically you have to have the knowledge of the organisms which could be possibly causing that syndrome.
All right. So I think the primary thing that we need to take care of is being a good clinician to try and diagnose it and bring the possibilities to a minimum so we know exactly what we're treating with. I think the next question is quite interesting. How useful can be a very rapid AST that tells an MIC but does not inform about the bacterial species? Dr. Subi, would you like to answer this one?
So see, there are a lot of molecular tests and diagnostic tests which are, coming up in the market, and we have been using them for the diagnosis of organisms. On the other hand, unfortunately, to know the sensitivity of the organisms, we have to wait for the cultures and then do the antimicrobial susceptibility testing. That still remains the gold standard. So that is definitely something which we also feel sometimes, we don't have the sensitivity early in our hands, but then that is the situation at present. And therefore, till we have at least 48 hours after the cultures are positive and then sensitivity testing, that takes that much of time. So there is nothing like a very good rapid AST testing as of now with us available.
Can I
Okay.
add?
Yes, please.
Yeah. Now, there is a prize called Longitude Prize. It's a 10 million pound prize announced by it's an international global prize announced by the British Prime Minister. We started that prize in 2014. And after 10 years, after assessing more than 400 applications from startups and companies, scientists from around the world, we have identified one device that identify urinary tract infection within half an hour and provide us susceptibility within 45 minutes. This is one of the examples. We are going to announce that in June. That is one of the examples, and that's a revolutionary technology. We call it as, as important technology, as complicated as a space mission. And we are going to, and that company has brought that space mission technology to the bedside. This can be done in the bedside by anybody, a nurse, a doctor, anybody. This is one of the examples of rapid diagnostic. I can tell you that there are dozens of rapid diagnostics working on respiratory infection, urinary infection, mainly, and a few other infections. And these will come to the practice probably within 6 months to 1 year, one by one. And some of them are, I would like to say, revolutionary technology, including from Indian startups. I'm proud to say that, including from Indian startups. And these rapid diagnostics will be extremely useful in antimicrobial stewardship. And this may revolutionize how we prescribe antibiotics when a patient is coming to emergency or to our OP. Let's keep our eyes open.
That is truly outstanding news, sir. Thank you so much. The next question is, what is the panel's opinion regarding starting antibiotic coverage for carrier cases? I think I'll leave this open to the panel. Anyone who'd like to answer this? Kayur, would you like to take this?
Could you
Said for
please repeat it?
carriers, right? Yeah. You
Yes.
want to take this, Kayur?
No, ma'am. Please go ahead. Please.
So, when we say treatment is mainly for pathogens, those organisms which are the reason for infection at present. Now, treatment of carriers may not be necessary in all the cases, and there are a few areas and a few infections where you need treatment for carriers. And I won't go into the details, but what I understand from this question is the person who has asked this question means to, wants to ask the treatment of organisms like colonizers or something. That is what I understand from this question. And I also got a question on my on this group that, should we treat the colonizers? So the person who has asked this question has said that before, we should get rid of the colonizers so that they don't cause any infection, something like that.
Yes.
Yeah. So we need to be very, very clear about this concept that our human body is full of microorganisms, and the microbiota, all the organisms are not bad organisms. So these microorganisms, they are a very, very major part of our immune system. So especially the gut flora. So we don't have to eradicate the colonizers. We don't have to eradicate the organisms which are present just, as a part of our whole system. It is the pathogens which need treatment. And if we talk about the treatment of carriers, like, in patients, enteric fever, the salmonella. So there you have people who are carrying salmonella in their gut. So then there may be certain areas, for example, if I talk about an institution like a hospital where, salmonella carriers are working. So there we do the surveillance and treat them so that we don't have those people working in the hospital settings. So, there may be areas where you need treatment of carriers, but you do not need to treat colonizers. Okay.
Thank you so much, ma'am. I understand we have a little bit of a scarcity of time, and I apologize for asking so many questions. I think these questions have been amazing. I wish to ask if the panelists are okay to answer one last question that I have gotten repeatedly. The question is what to do about OTC antibiotics. How can anyone try and manage an OTC antibiotic sale or OTC antibiotic distribution? Because that is something that people are asking multiple times. That is one thing that is causing resistance or causing self-prescription on a large scale. Dr. Anup, Dr. Surbhi, would anyone like to answer this one?
So here, I would just try to highlight a step which the government of Kerala has taken recently. So basically, it has passed a rule saying that if any pharmacist is caught doing this OTC sale, the pharmacy registration would be cancelled. So in Kerala, it is extremely difficult for you to walk into a pharmacy and buy an antibiotic.
Okay. So I think changes at a legislative level are all that can be done to hopefully prevent this side course of this angiogenesis road. Okay, I think we'll have to end our question and answer session now. Thank you so much for all the viewers for all their questions. We'll try to keep answering all the questions on the WhatsApp group after the call as well. If there are any questions that are unanswered, please do let us know. We'll be happy to answer them one by one. Okay. Thank you so much to everyone that has joined in. Thank you so much for everyone who has taken that time out on their Sunday evening, left their IPL matches, and come to watch us speak on an extremely important topic and a topic that is close to all of our hearts. It is something that we, not just as medical students or doctors or future doctors, but something that we as humans need to take care of, because this is one of the few defenses we have against the revenge nature takes on us. And I think being educated in this aspect is supremely important. I'd like to thank the AMR Declaration Trust. I'd like to thank the Rotaract Club of Medicrew for offering us this opportunity to come out and speak and address all of these wonderful doctors and listen and from the clinical experience of all of these wonderful doctors and panelists about what they have learned, about what their experiences are, so that I, as a future clinician, can also, first of all, not make these mistakes and hopefully have a safer patient and have a safer cure for a patient. I'd like to also thank Dr. Surbi for her valuable time, her extremely imperative insights on antibiotic resistances, and all of her astute answers. I'd like to thank Rotaractor Keyur Subnis for his time and for his valuable insights as well. I'd like to thank Dr. Anu, Dr. Abdul, Dr. Vasant, all of them for their time, for their cooperation, and for all of their support that they've given in this project that is extremely close to my heart. I hope that we keep having these sessions in the future and we collaborate positively to bring about positive change in the world, one step at a time. Thank you so much.
Thank you.
To all of the audience, we'll be sending the post-event form on the YouTube live chat. So please do fill that form. Only those who fill the post-event form will be able to get their certificates. Thank you so much.
Okay, all right. So can you keep the form open till 7:15?
Can you repeat once?
Yeah, keep the form open till 7:15.
Okay, okay. I've told Shweta, she's the one who's taking care of that.
ठीक है, चल.
All
Okay.
right.
Great job, guys. You both were amazing. क्योर क्या तोड़ दिया भाई?
यार, you know, why did you text her the group की उसका आवाज echo हो रहा है? मैं